So my remit is PVCs, and we've covered some in the earlier talk. But I wanted to start by providing my take-home messages. And this is largely what I say to patients when I meet them in clinic and they have symptomatic or asymptomatic PVC. So I say to them, look, these are common. Everyone gets some. Nearly everyone gets some if you monitor patients for long enough. But some patients will have more. Some patients will be driven mad, but most patients don't have any symptoms related to PVCs. But PVCs probably are more common if you have structural heart disease. They clearly can happen in a totally normal heart structurally or in structural heart disease. And I think it's key that we remember that the vast majority of PVCs or patients with PVCs run a benign course, and reassurance is a really powerful tool. And then finally, in the last 5 to 10 years, recognition that there's this condition called PVC cardiomyopathy. So you take a totally normal heart, you subject it to an electrical problem, which is the PVCs, and they develop a reversible heart weakness that needs treatment. So the first case provided to me is a young woman who's got basically asymptomatic examination finding of an irregular pulse, and an ECG demonstrates ventricular bigeminy. She's seeing you with an intercurrent infective illness, and there's nothing else on sensitive history or examination. And this is really the vignette of a well patient that can be reassured, that perhaps needs a little bit of extra testing, but it's highly likely she's going to be reassured. We'll come back to the case after talking about some more PVC concepts. The second case, a little more worrying, a 35-year-old male patient, not only symptomatic from missed beat, skip beat, heavy beats, but's now developed some effort intolerance, some breathlessness with activity. So that's a red flag, I think, and it warrants further consideration. Same findings on examination, and again on ECG has ventricular bigeminy. So just to discuss concepts and how I think about PVCs. So PVCs don't come randomly from inside the heart, and people with totally normal hearts, the PVCs often arise from around the valve annually. That's where normal heart muscle connects into either connective tissue or there's myocyte fibre change in direction. And so the vast majority of these PVCs come from the right ventricular outflow tract just underneath the pulmonic valve, but can come close to the aortic valve, the mitral valve, or the tricuspid valve, or in some patients, the intracavitary structures, so the papillary muscles that I think you can see in the middle of the heart in any case. And just a reminder, so in the upper right picture, that's a cardiac MRI patient with an ICD, VT, PVCs, and cardiomyopathy. And you won't see too many of these, but there's a little white stripe in the interventricular septum, and I can't make the pointer work. You can only just see that. And so you can have PVCs associated with structural heart disease. So when you see PVCs, you've got to have a think, does this person have structural heart disease? A bit more on PVC cardiomyopathy. So it's the premise that you take a totally normal heart, subject it to PVCs, and a patient can get heart weakness or cardiomyopathy, and it's usually reversible. So if you can take the PVCs away by one way or another, the cardiomyopathy will resolve. And the burden required for that's not totally clear. We think it's probably 20 to 30%, but there are reports down to 10%. Holter monitors a 24-hour snapshot, and so it's not always reflective over what happens across the rest of the year. And there may be vulnerable hearts that develop cardiomyopathy at lower burdens. But I think you have to say that the vast majority of patients with frequent PVCs do not go on to develop cardiomyopathy. So incidence, I don't know, we probably in New Zealand do less than 100 PVC ablations per year. In New Zealand, with 4 million patients, a few percent will have bigeminy. So out of 100,000 people, we're really only treating 100 with ablation. The incidence or prevalence is probably pretty low. But if you look at ablation data sets of people that come to see me and have ablation, probably about 30% of those patients have PVC-related cardiomyopathy. So to think about who you should be referring to us, the way I think about it is, well, who's likely to either have structural heart disease or need an indication for treatment. And so who do I treat when I see patients with PVCs? And one of the things about my practice and having a reputation for treating PVCs is that I often see a lot of patients with PVCs. but probably the vast majority I still am not treating with medical therapy or ablation. So who should be referred for consideration of treatment? Those with significant symptoms, those driven mad by their symptoms. I think that they warrant referral and they warrant treatment. But I think minor symptoms, patients should be mostly reassured because our treatments aren't perfect. There are some risks inherent to taking antiarrhythmic drugs or or an ablation procedure. And so I treat people with significant or problematic symptoms despite reassurance, and those with LV impairment or in the small print other complications of the PVC. Treatment options, as I said, I think that reassurance is a really powerful tool, and so if the rest of the ECG is normal and if they've made it to me, they've had an echocardiogram, that's normal, I mean, those people are getting very strongly reassured. And I think that is a powerful tool because 3 months later when those people come back to clinic, they're often less symptomatic or asymptomatic anecdotally. Medical management, at your level, it's mostly going to be the simple treatments like beta blockers that have been proven beneficial in multiple other heart disease states and virtually without risk in most patients, or less likely calcium channel antagonists. And both of those probably have a modest effect at most on PVC, sometimes occasionally striking, but probably modest, but probably also associated with a reduction in symptoms. The additional management that are going to be undertaken at a cardiologist or a cardiac electrophysiologist level, antiarrhythmic drugs, flecainide, sodium amiodarone would have access to in New Zealand used commonly, or ablation. And ablation would probably be approaching first line in patients with cardiomyopathy. You really want those PVCs to go away. It probably is the most effective treatment, but you have to take a little bit of upfront risk to have that long-term benefit. So when you see a patient with PVCs and you've taken a careful history and examination, what tests? I mean, I think an ECG is probably reasonable in most of these patients. So if they've got just an irregular pulse, you want an ECG to make sure it's not atrial fibrillation and make a diagnosis of PVCs. And then in selected patients, probably blood testing. And I think if someone's breathless, an X-ray and other blood tests, including BNP, are reasonable. And that helps guide referral to the appropriate specialty. And people with PVCs could have lung disease, for example. So getting to the question of who should be referred, like we've talked about, I think that you should be referring people with either significant symptoms or whether there's concern for structural heart disease. So that would be patients that have examination abnormalities. You've heard eloquently about not ignoring ejection murmurs today. Those with an abnormal ECG. So more importantly, I think, than looking at the PVC, although I can usually tell if that's where that's coming from in the heart and sometimes whether that's prognostically important, look at the normal beats. Is the normal beat that goes down the heart's intrinsic conduction abnormal? So you send an ECG through to us, we send it back to you and say, well, look, the intrinsic conduction's got left bundle branch block. So those PVCs are much more likely to be important. That person definitely needs to be seen. And those with a high burden of PVCs. Now, I think that's a little hard to definitely determine, and people I've heard, and like mentioned earlier, 2 or 3 PVCs on an ECG. Whether that should be on 2 consecutive ECGs, I think that's also a reasonable thing that could be considered. So just one caveat with ECG interpretation. Now, these are often sent through to us and we can provide comment. This is a patient in sinus rhythm with normal electrical conduction on the normal beats, and there's some extra systoles. And they are a little broader, but when you look at V1, and I can't point to it unfortunately with this pointer, there's a P wave on the back of the T wave. So this is actually an atrial ectopic with aberrant conduction. So this is even, this person definitely should be reassured. Now, getting back to our cases, the first one's the young woman who's otherwise well, asymptomatic finding of an irregular pulse in the ECG with bigeminy. This is her ECG, just an example of one. So the conducted beats are totally normal. The extra beats, we look at that as cardiologists and say, well, it's negative in V1, it's positive in the inferior leads, it looks like the typical benign form of right ventricular outflow tract ectopy. So that's going to be reassuring, but probably reasonable to pursue testing, particularly if the PVC persists. And so ECG repeated after the recovery of the flu-like illness, PVC still present, so seen in cardiologist clinic. Got a burden of around 40% on Holter monitoring, but normal LV function. So there's, at this stage, there's no indication to treat. So there's no data to support treating asymptomatic patients with high burden PVCs improves outcomes. But I think it's important to follow these people, and I personally in my practice follow people with burdens of between 10 and 20%, usually more than 10%. I would keep them under annual follow-up. So this patient reassured and as described, follow-up planned. The second patient, this is the slightly more concerning one where there was some effort intolerance and again in bigeminy, and was also symptomatic from the PVC. So it needs to be seen for a couple of reasons, to include or exclude structural heart disease, but also for management of the symptoms. So another ECG with PVCs on it. So in this occasion, the intrinsically conducted beats aren't totally normal. It's only mild, but you might get a report back saying LVH by voltages. So V2, there's a DPS wave. V5, there's quite a lot of R wave. When you add that up, it meets criteria for LV hypertrophy. And then in addition, the QRS complex and lead 3, there's a little bit of delay there. I mean, it's a slightly abnormal ECG. So there's some things here to say this person needs to be seen. So seen in clinic, we've established they've got NYHA2 breathlessness, they've got a lower PVC burden, but this person's got LV impairment. And when you take the history, they'd been seen 5 years earlier with SVT and had, at that point, normal LV function. So this is either someone who's developing cardiomyopathy, and as a part of that, they've got high burden PVCs, or a PVC cardiomyopathy, or the truth might be a bit of both. So this person who then failed medical treatment came along and had an ablation. So on the left hand, that's X-ray. Coming down from the upper left side toward the middle of the heart is an ablation catheter sitting in the aortic root. And this is real-time intracardiac echo on the right side. And although I'd be able to show you with a pointer, that's the aortic valve, and the ablation catheter is in between the upper right and the lower right, sitting at the junction of the left and right cusp. So these kind of things allow you to treat these arrhythmias with ablation successfully and mostly safely. There's some important real estate in and around this part of the heart, like the coronary arteries, the conduction system, the valves themselves. When you're doing ablation, you want to avoid all these things. And we have all these tricks that we can use to make it as safe and effective as possible. So this is post-ablation at 3 months, and at this stage he's had an echo showing slight improvement in LV function. Often takes up to a year after an intervention to assess the full effect of that intervention. So just getting back to the take-home messages, these are common, mostly benign, but in some patients indicative of need for further investigation to exclude either structural heart disease or in high burden a PVC cardiomyopathy. PVC cardiomyopathy is an entity that we do need to keep an eye out for. And the indications for therapy in my mind are either significant symptoms, so not just modest symptoms, or LV impairment. I'm happy to take any questions.
Thanks, Jamie. That was a really enlightening talk, and I must say I speak from first-hand experience. I've had 1 or 2 of my patients through your hands, and fantastic results. No questions have come up here, but I'll crank on with a few. One of the things that probably happens out in the community is patients do get seen fairly frequently with palpitations. And when the resting ECGs are done, they are entirely normal, and doctors don't hear a murmur, and so the patient's sort of sent off and reassured, but they keep on sort of recurring. What's your take on these alive core type devices in that sort of situation? Do you think they're helpful?
I think they probably are. There's direct access to them. There's no wait list. If the patient has the means to pay for them, you do get symptom rhythm correlation. The only other way to get symptom rhythm correlation in people with rare symptoms is to implant one of the implant a monitor. That's about $5,000 in an invasive procedure. So I think they're useful. They mostly provide interpretable data, and people that came to our exercise talk this morning, we talked about these. It's 2 thumbs on a thumbprint that gets uploaded to the ECG and then electronically can be sent to a GP or cardiologist by email. And I've found them relatively useful to work out if the patient's having atrial fibrillation, for example, post an AF ablation. But at times you can't determine what the rhythm is, and maybe you can say there's tachycardia. But I think there is use to them. I'm told they're around $200 to purchase.
Alrighty. And just in terms of beta blockers, there's a question here. Yeah. You mentioned that the RVR flow tract version respond. Do you have a particular preference for a beta blocker?
I mostly use metoprolol because I'm most familiar with that. So metoprolol CR, starting dose 47.5 or 23.75 in heart failure. And young well patients can't always take the upper end of doses, but maximum dose 190.
Question on familial cardiomyopathy. Do you think the PVC cardiomyopathy may have a familial component to it?
I think, so I think there's a vulnerability factor that we don't totally understand. If you have the vast majority of patients with high PVC burdens not developing a cardiomyopathy and then some doing it, there is an underlying vulnerability, and whether that's a genetic factor or some other environmental factor, I think it remains to be seen.
There's a question on calcium blockers, diltiazem. Would you try beta blockers and then go to a calcium blocker?
Yeah,
or?
And I think that's reasonable. There's virtually no harm in most scenarios with that. They're only modestly effective, I think, but they can be useful for some of these PVCs because they change calcium handling and triggered activity, which is responsible for some of the PVCs. So I think that both of those things are a reasonable thing to do for a symptomatic person with a structurally normal heart after they see us or before they see us, before considering antiarrhythmic drugs. As I said, some downsides, and ablation, upfront risk, longer term gains.
Okay. And caffeine, obviously.
I think the effect of caffeine on arrhythmia is probably overstated. So I advise patients just use it in moderation, unless they're the very selected patient has one coffee and goes into tachycardia or gets PVCs. So I think sensible use of coffee, I don't change that.
And then there's a question here on cut-off threshold PVC burden versus medical therapy. Do you have a sort of a percentage threshold, or do you base it on symptoms?
For referral or for ablation?
For medical therapy versus
No, I mean, so in general terms, if they're symptomatic, it doesn't matter how many PVCs they're getting. They may warrant treatment. You can't do ablation if the burden's really low because you can't map them, you can't ablate them. So those people need to be managed medically. So if your indication for treatment is symptoms, I think medication or ablation's fine as long as there are enough PVCs to ablate. I think if your indication is PVCs and cardiomyopathy, if it's one unifocal PVC and you think on the ECG morphology that you can ablate it, then ablation's probably better than, for example, amiodarone, sotalol, and fleconide's contraindicated in structural heart disease.
And what sort of risks are you quoting your patients for, let's say, an LVR flow tract procedure versus an RVR flow tract procedure?
So in both, most of the time goes fine. On the right side only, probably 1 to 2% risk of complications. That's dominantly vascular access. On the left side, 2 to 3%, with a small additional risk of collateral injury to the structures we talked about, and a pretty small risk of stroke. And so I think it's still doable, and I think it's reasonable when you compare that to long-term fleconide with its risks, or long-term amiodarone with its risks.
Okay, we just had a few more roll in here. Any role for digoxin?
I don't think so. I mean, I hardly ever use digoxin now. There's a positive association with mortality in higher doses and heart failure. So I virtually never use it.
And then the sort of threshold for saying PVCs are of high frequency would be 10% or 20%?
Yeah, that's probably arbitrarily defined. I follow people with more than 10%, so I think that's reasonable. How that exactly works to a single 12-lead ECG, I struggle with. 2 beats on an ECG, I don't know. Maybe repeated ECGs.
I think that's the full set. Thanks, Jamie. It was great.
Very good.